This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Trey Bateman from Atrium Health, Wake Forest Baptist in Winston-Salem, North Carolina. Today, I have the pleasure of interviewing Amy Brodtmann, who is the director of the Eastern Cognitive Disorders Clinic and a professor at Monash University and the Royal Melbourne Hospital. Amy is the senior author on a paper published online in Neurology Clinical Practice on October 8th in 2024 titled Frontotemporal Dementia Differential Diagnosis in Clinical Practice, a single-center retrospective review of frontal behavioral referrals. Amy, thank you for joining me today.
Thanks, Trey. Always delighted to talk about clinical aspects of neurology.
So I review most of the referrals that come to see me in clinic, and among the most challenging that I have to triage and go through are these with frontal network impairment, behavioral changes, impulsivity, executive dysfunction, and the like. You and your colleagues reviewed all of the referrals for the Eastern Cognitive Disorders Clinic over a 9-year period with referrals related to frontal network impairment or a diagnostic question of frontotemporal dementia, which ended up being about 161 cases out of 611 total referrals with data available over that time period. Can you give us a brief overview of the clinic in terms of catchment area? What sorts of referrals typically make it to a quaternary referral center there? And then what you found in terms of who was referred for frontal network impairment and what the major takeaway from the study was.
So the clinic is based in the eastern suburbs of Melbourne. Melbourne's got a population of about 5.3 million people in Australia. It's either the first or the second biggest city in Australia. It's always competitive. The Australian system includes universal healthcare, which is our Medicare, and that is actually across the board. Anyone can have Medicare. Every Australian citizen has Medicare, and it covers most public in- and outpatient referrals. When I first set the clinic up, in fact, when I returned from my postdoc in Chicago with Marcel Mesulum, I initially designed it to be a nested community hospital service with a special interest in people referred with young onset dementias, atypical dementias, and frontotemporal dementia. So our actual geographic catchment is just under 1 million people living in an area spread across about 3,000 square kilometres, about 1,100 square miles in Melbourne. And it quickly became a statewide and then a national referral service as well. So we see people from all over Australia, a real mix. The advantage is that once they're referred, they can have indefinite review. So we offer in tandem with the other services that are available. We've got a gerontologist or a geriatrician-led memory clinic as well that usually see older and frailer people. So what was interesting about this case mix is that not all the patients that had been referred over that 9-year period had available notes, etc. But what we found is that the people who were referred with query frontotemporal dementia, does this person have frontal behavioural impairment, that about a quarter of them actually ended up having behavioural variant FTD, and just under half overall had other FTD syndromes together. But then the other commoner diagnoses were what you'd expect, which is a primary psychiatric disorder, which was very common, again, around 20%. And then there was a whole mix of other conditions, including vascular cognitive impairment. So we did really find quite a range of different diagnoses for the same referral, if you like.
One of the things that I see a lot of is people are referred with behavioral changes, and there's a difference in the degree of behavioral changes. I get a lot of folks with fairly typical Alzheimer's disease in some instances, and that impulsive behavior is sometimes mischaracterized, especially in my younger onset patients, as indicative of a real behavioral variant, when in reality it might be just more of some impulsive behavior that's challenging, but not really characteristic of a decline in socio-emotional cognition. Did you all see a lot of that type of thing with the referrals?
Yes, that's the commonest. Behavioural change, marital discord. So relationship issues are a really common cause of referral, or prompt for referral, I should say. We see a lot of people who are referred with impulsivity and disinhibition. Interestingly, they weren't really the people who ended up having a diagnosis of BVFTD. They were much commoner in people with primary psychiatric disorders. young onset Alzheimer's disease is really difficult, particularly if it's a frontal AD from BVFTD. Obviously, we've got much better ways of looking at that now, particularly with amyloid PET imaging and potentially with blood biomarkers, which we didn't look at in this particular study. So I know my trainees, my fellows often say, oh, this person's being referred with FTD, they must have it. And they seem to sort of be able to change the actual diagnostic categories to fix what they think. I think the lens of how we're actually approaching these patients is important. We need to say this person's presenting with frontal network dysfunction or frontal network impairment doesn't mean they've got FTD. Could be many things. Let's look at the person as a whole.
Syndrome before etiology always. That's sort of become my mantra. I've become radicalized that we always have to identify the syndrome before we even begin to think about the etiology, because otherwise we kind of get led down these wrong paths. And it seems like maybe the referral process is almost an example of that, because folks jump to FTD sometimes before that etiologic workup is done. And that's where your clinic is. One of the things that a clinic like yours is doing is really providing that etiologic assessment to get to the right final diagnosis.
Yeah, 100%. And I think it's difficult. I love that as a mantra, syndrome before etiology. I think that we often are triggered by certain things in the referral. And, you know, when we get informant reports where that we can almost feel pressured to make a diagnosis. And it's hard, you know, sometimes people come with an expectation of something in particular if they've been reading. But I think that we need to try to take away our own cognitive bias when we're starting to look at people with different syndromes. I suppose what was interesting, and this would be another paper we may do down the track, is that we looked at the actual referral question here. However, when I look at the patients who've been referred to the clinic with BVFTD, it actually only captured less than half of the patients that we've seen. So most people getting referred with FNI don't have frontotemporal dementia. And in fact, most people with frontotemporal dementia aren't getting referred with a question about frontal behavioural problems.
I feel like frontotemporal dementia is one of those diagnoses that I teach my trainees is among the most prone to having diagnostic refinement down the road and the most prone to misdiagnosis in both directions. We both call things FTD that isn't, and we fail to capture things that are FTD. And so it goes both ways.
I couldn't agree more. And I think that there's a condition that we included in this particular review or audit, which is the FTD phenocopy described by John Hodges and others. And I think that there's often a very strong theme of marital discord. And specifically for this study, we only included people and made a diagnosis of the phenocopy if we followed them for 5 years. I mean, that's a long time. We can do that with our clinic because that's how it was set up. But 5 years, most people don't have that luxury to be able to do that. And it's really tough. We have found, and again, it wasn't so much in this paper, but we've published this elsewhere. We have found that the blood biomarkers are hugely useful for the phenocopy because they're normal in phenocopy and they're abnormal in FTD. Pretty much nothing's 100%, but it's very useful.
Neurofilament light, is that often what you're using there?
Yeah, specifically neurofilament light, just as a non-specific marker of neurodegeneration, is terrific in distinguishing both patients with a primary psychiatric disorder and the phenocopy, which can be really a tough diagnosis in clinic. Lots and lots of time spent discussing with these families when it's not FTD.
Couldn't agree more. Moving on to what you all found in the differentiation process, one of the things that I thought was really important is that on bedside cognitive testing, there was a trend towards those with AD performing worse, but no real difference in those with behavioral variant frontotemporal dementia and a primary psychiatric disorder. And that really highlights behavioral variant FTD, often sparing objective cognitive testing. The Cambridge Behavioral Inventory seemed to help. For those not familiar with that, can you describe what that is and how those scores helped to differentiate between groups?
Cambridge Behavioral Inventory, or the revised version, the CBIR, it's a 45-item test that's under 10 domains. Again, John Hodges created it with his group 15 years ago in response to work he'd done and others looking at symptoms and behaviours that differentiate people with FTD from those with psychiatric disorders. There's a great paper in J&P in 2000 where they looked at this. And I started using the CBI in clinic back in 2011, mainly because what I thought we were capturing in our history and in some of the other scores were not really sensitive necessarily to FTD symptoms. And the two items that I found particularly useful, which has been shown in other studies, is that the eating behaviours and stereotypic or stereotypies, so stereotypic motor behaviours, were particularly good in differentiating. There's a lot of work that's been done in eating behaviours, as you know, in patients with FTD. And one of the big things is this sort of sweet food preference or carbohydrate preference that they have. And certainly when it's there, it's great to differentiate. But a lot of people, as they develop dementia syndromes, often have a simplification of their diet anyway. And if they've always had a sweet tooth, they tend to eat things that are sweet anyway. So it's a helpful differentiator. And in our study, we showed that it was very useful. We send it out to participants or our patients before they come to clinic, and a loved one or a neighbour or a caregiver will fill it out for us and bring it in or do it while they're waiting to be seen. And I do find it is really helpful because it often prompts that person to actually think about their behaviours. And there's also a text box section where they can write in anything that they've observed, which can be very useful. So you get that informant report when they're reflecting.
The eating behavior is something that I've seen obviously very helpful in clinic as well. Does the CBI provide some differentiation on sort of severity of that behavior? One of the things that sometimes comes up in clinic is misattribution. So what I mean by that is, someone will say, well, they crave carbs all the time. They finished a whole bag of potato chips and, there's been times where I meet the criteria for that one versus say, our patients who people are literally putting padlocks to keep them away from eating the 5 or 6 boxes of Pop-Tarts that they may eat.
I think that's a really good discrimination. And when the trainees come and say, oh, there's a sweet fruit preference, they never ate dessert and now they eat it, I'll often say, well, are they eating jam or preserves from the jar? Are they eating sugar from the actual sugar container? And I think that that's really true because there's lots of conditions where we crave carbs. I mean, if you're sleep deprived, you crave carbs. For our listeners who've been pregnant or who have breastfed their babies, oh my goodness, you crave carbs. So there's times in your life that, if you've just run a marathon, you probably do too. I think that we need to take those sort of context-specific things away, and they are abnormal eating behaviours. What I think is often really useful is we forget how much there are eating behaviours in our society. Each society has a specific way that we accept for people to eat at a table. And so a loss of table manners and of decorum around eating events, I think is often very useful. You might eat a piece of cake, but if they eat the entire cake and they eat food off other people's plates and they're actually, taking leftovers and going and taking things out of the bin, then they are not acceptable eating behaviours. And they're the sort of things that you'd really say, okay, that's not right.
I think my favorite description of this distinction, I believe I can attribute this to Dave Jones at Mayo, who's described the difference between these impulsive behaviors and these real behavioral variant behaviors as like we all have a list of how we should behave in society. And the impulsivity, we've all got the list, but we can't follow it in that case. But the folks with a true behavioral variant, they're not reading from the same list. They've got a different rubric for what constitutes normal and acceptable behavior, and they're clearly not on the same page often. And so you see these real markedly divergent behaviors.
That's right. And I think that it's not even that they're not reading from the list. They don't have that list, particularly with behavioural variant frontotemporal dementia and semantic dementia as well, both of which have extraordinary social and emotional cognitive deficits, that loss of those frontoinsular connections. they really profoundly lose the ability to read the room, to understand social interactions, to understand emotional cognitive cues as well. I vividly remember one of my patients, their wife came in to see me and she was very upset because she said, I came back from a funeral of one of my best friends and I was crying and my husband said to me, why is your face wet? He just lost that list. He'd lost the list. He lost the fact that, we weep when we're sad. And so I think that those profound impairments, you don't see those in a primary psychiatric disease. You don't see those in vascular cognitive impairment. You don't really, in my experience, see that in someone with frontal onset AD. I mean, never say never, but that's in terms of generalizations.
That's been my clinical experience as well. One of the things that this paper highlights, I think, really well is how heterogeneous referrals are for frontal network impairment and frontotemporal dementia. And as you mentioned earlier, a plurality, 27% or so, did have behavioral variant frontotemporal dementia. Many others had a neurodegenerative disease of some sort, but 16% had a primary psychiatric disorder. And that differential consideration garners a lot of attention, and rightfully so, because primary psychiatric disorders are intervenable. We can intervene on the course of that disease. And I tell my residents that FTD is very, very easy to suspect in a lot of folks. If you read the diagnostic criteria, it becomes easy to try to shoehorn people into fitting that for possible behavioral variant frontotemporal dementia. So I think when you haven't seen a lot of frontotemporal dementia, it becomes very easy to do that and make people fit with that diagnostic criteria. The other challenge is people have a psychiatric disorder. If it's new onset and they're older, that's usually a pretty concerning sign. But long-standing psychiatric history tends to be, I usually think of as being more suggestive of a potential psychiatric etiology. Can you walk us through the findings related to psychiatric history and help our listeners understand how to consider that in the evaluation of patients with frontal network impairments?
So I'll break it down into two parts to the answer. The first is in terms of history of psychiatric disease. So we found that really helpful, particularly a long history of psychiatric disease. One of the tables in the paper, we look at, last 5 years, 5 to 10 years, 20 plus years, etc. And we found that people with a really long history of depression or anxiety were more likely to end up having a diagnosis of a primary psychiatric disorder. However, we were surprised at how common it was for patients with what we, ultimately had a diagnosis of behavioural variant FTD, had this psychiatric history. And it could have been distant, but it also was more likely to be more recent. And I think it really speaks to the complexity. I mean, since we started to explain and understand this hexanucleotide repeat, the C9 ORF72 repeat expansion, since we've started to describe this genetic condition, I think that it really has blown the minds of FTD referrals. I mean, first of all, we talk about frontotemporal dementia. These people get cerebellar and parietal atrophy. Go figure. It can be incredibly slowly progressive. We've published a case report of a man who's still going 25 years down the track with really slowly progressive disease. And in addition, these are the people who present with a history of late onset schizophrenia, or late onset hallucinations and delusions, and sometimes they can have quite bizarre psychiatric presentations. There's often a family history of bipolar affective disorder and schizophrenia and dementia in young onset. So I think it really, Bruce Miller, who many of your listeners will know is a doyen of behavioural neurology in San Francisco, often talks about the border zones of neurology and psychiatry, and there can be no better example. But to break it down a little bit, it is helpful, I think, if someone's got a long history of psychiatric disease, particularly untreated, then I think we think more likely to be a psychiatric diagnosis. If someone's got more recent events, still could be, but think about FTD.
I think the C9 cases are the ones that sort of keep me up at night when I'm differentiating between primary psychiatric disease or FTD phenocopy or BVFTD. I think we all have these cases that the C9 doesn't always follow the rules or the diagnostic criteria in this case. And so I've had some really challenging cases there. And I feel like a lot of those patients get discounted by some referral services or some neurologists. They'll sort of see, well, this person has a psychiatric disease, and so that's going to be the answer, not this frontotemporal dementia. But I think that as your experience with these referrals points out, I think Norman Geschwind, who is or should be familiar as the father of modern American behavioral neurology, had said that it must be realized for every behavior there is an anatomy. And so these patients sometimes come in with what looks for all the world like a psychiatric disease, and with follow-up and careful consideration, sometimes they end up with one of these C9 mutations. For your phenocopy cases, do you consider having a C9 genetic mutation analysis really central before you determine that you think somebody has a phenocopy syndrome?
We do now. Back in 2010, when we were first seeing these patients, well, it wasn't described then, but it was hard to do. We didn't do it, but we do now. And in fact, in the take-home points of the paper, one of the last point is actually, genetic referral for determination of the C9 repeat expansions. I think it's really important for FTD. It's important for making an earlier diagnosis in cases of high suspicion and low clinical certainty, because I think that if we're thinking about it, sometimes I think it can put our mind at rest. If we're seeing someone that we're puzzled by, then it can go both ways. I've been as surprised with a negative as with a positive. And certainly for families, the sense of closure that diagnosis can give for a slowly progressive FTD, if it is genetic, I don't think we should underestimate that.
I agree completely. I sometimes think that much of modern medicine focuses so much on how can it, quote, change management, unquote. And I find myself having to defend the position that knowing what's happening to yourself or somebody that you love is an end in and of itself. Having an answer is, I think, incredibly powerful for many of these folks. Have these findings had any impact on your practice or how you manage referrals, triage referrals for patients with questions related to FTD? And maybe more importantly, what recommendations would you have for a neurologist in the community who may be seeing a patient this week with frontal network impairment problems?
I think two things came from this audit or review. I thought that the most important thing was the commonest diagnoses for people who were referred with potential frontal network impairments were BVFTD, a primary psychiatric disorder, and vascular cognitive impairment. What we found is that they're hard to differentiate on history alone, which I think is where the Cambridge Behavioural Inventory comes in. Imaging is obviously really important too. Those with BVFTD might have a classic frontotemporal atrophy, or semantic dementia will have a classic anterior temporal atrophy, and so on. And those with vascular cognitive impairment are going to have white matter, hyperintensities, infarcts, enlarged perivascular spaces, and potentially prior strokes. As I said before, their social and emotional cognitive deficits are different from the BVFTD. They'll have apathy and poor motivation and loss of empathy, but they do not lose the social and emotional cognition like people with BVFTD. They know, but they just don't care. I think to colleagues who are seeing, a patient this week or tomorrow with potential frontal network impairment, then take a great history, including a past psychiatric history and a medical history as well. We found that medical comorbidities were actually really common in people with FTD, something we don't often think about. We're starting to understand that particularly some of the genetic conditions, there's a higher incidence in people with inflammatory conditions in the past, so that the genetic mutations overlap. They probably are inflammatory pathologies. If you're seeing someone, see if you can incorporate a behavioural scale like the Cambridge Behavioural Inventory. It's available for download. Really look at their brain imaging to make sure that there's none of the classical imaging signatures, and for evidence, obviously, of small vessel disease and vascular disease. And I think that if you do have access to blood biomarkers, check their neurofilament light chain, check their NFL. We found it very useful for distinguishing patients with FTD from primary psychiatric diseases in young onset dementia.
Fantastic point. I wonder if you run into the same thing that we run into here. I tell all of the people rotating in my clinic that if you have an MRI and you don't have the images, you don't have an MRI. You've got to look at it yourself, because many of the things that we care about, the old adage that you're doing the brain imaging to rule out a bunch of bad pathologies is just not true for some of these conditions. We are using it to rule in what we're looking at. And the number of times that profound asymmetrical atrophy is missed in the report from the community is just really high. So you got to look at your own images, I think.
Absolutely. If any of my trainees or prior fellows will listen to this, they will be rolling their eyes, because I don't believe anything until I've seen it. And they'll often say, oh, well, the report said, and I'm like, I don't care about that report. We review all of the imaging in our meetings. I certainly don't believe anything until I've seen it. True of FDG PET as well. You have to look at that imaging yourself, because you've got a specific question that you're asking that the radiologist might not be asking, and you've got information that the radiologist doesn't have as well.
Excellent point. It would be a lot harder to read 100 MRIs with no context and come up with some of the things. We have a different set of questions that we might be asking of it.
That's why I'm a neurologist.
Exactly. So in the few seconds we have left, could you summarize the key take-home message to remember about your work?
I think that the take-home points are not all frontal network impairment, not all patients presenting with behavioural change is BVFTD. There's a range of neurodegenerative and primary psychiatric disorders that can present with behavioural changes. We found that around 45% of those patients who were referred with this question ended up having an FTD syndrome, but that's really, I think, partly a bias of the clinic, the fact that we do see these patients. So that wouldn't be the case everywhere. I think that what was important in our review is that common cognitive screens and a psychiatric history and even the presence of medical comorbidities might not be helpful, but behavioural screens actually are. So just think about incorporating those into your practice. So giving a structured behavioural informant interview will be really useful, and remember to ask about stereotypies and abnormal eating behaviours. And the last thing was the point that I mentioned before, is that really consider genetic referral for those people where you've got a high suspicion but low certainty, because it can be really helpful and, in fact, life-changing for the people who get diagnosed.
Wonderful. Thank you, Amy, for sharing your findings with us, and thank you for taking the time to discuss this important paper.
Thanks so much, Trey.
I've been speaking with Amy Brodtmann, senior author on the paper titled Frontotemporal Dementia Differential Diagnosis and Clinical Practice, a single-center retrospective review of frontal behavioral referrals, which I would encourage everyone to read in Neurology Clinical Practice.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes, or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.